Thank you for joining me and listening to this mini series on osteoporosis. Today, we're going to discuss the pathophysiology of osteoporosis, risk factors, treatment options in terms of prevention and treatment of osteoporosis. The guidelines for the treatment of osteoporosis are available at the website below. Osteoporosis is a very important disease state within the U.S. More than 10 million Americans have osteoporosis, and nearly 33.6 million Americans have osteopenia. Incidents with regards to sex vary. About half of white women will develop a fracture in their lifetime, and 1 in every 5 men will develop a fracture in their lifetime. This number will increase with aging population. This graph depicts the relationship between age and bone mineral density. You'll see the solid black line is an ideal patient, whereas the dotted black line are patients with inadequate lifestyle factors, which we'll discuss shortly. This graph depicts the bone mineral density throughout a typical person's life. As you can see, bone mineral density peaks in a patient's 20s and then cumulatively decreases with time and then rather dramatically decreases following menopause. The pathophysiology of osteoporosis has a lot to do with bone remodeling. Bone formation is a continuous, balanced process that's coordinated by osteoblasts and osteoclasts. Bone remodeling occurs in order to get rid of old, weak bone and for regulation of blood calcium, as well as blood phosphorus. The osteoblasts in our blood build bone, whereas osteoclasts are the enzyme that cause bone resorption. These processes occur based on hormone regulation. Osteoporosis occurs when there's an imbalance in remodeling, particularly during menopause in females, because estrogen stimulates bone building, and when this is lost, bone mineral density drops significantly. As I stated in the previous slide, bone building and breakdown relies heavily on hormonal control. The first hormone that we think about is the parathyroid hormone, which is produced in the parathyroid gland. This is produced in response to low blood calcium and stimulates bone resorption in order to increase calcium levels in the blood. It also stimulates osteoclasts in the bone. Calcitriol increases calcium and phosphorus absorption. Calcitonin is produced in response to high blood calcium and stimulates calcium absorption and allows calcium to deposit to the bones. Sex hormones, such as estrogen, also inhibit bone resorption. There are two major types of bones that we think about when we're talking about osteoporosis. The first are the cortical bones. This type of bone is very dense and forms the outer shell of the skeleton. It predominates in the long bones, except on the tip. The second type of bones are trabecular bones. This accounts for about 20% of the bones in the body. These bones are rather porous. They form the interior structures of the bones, and they're found in the vertebrae, distal forearms, ribs, and hips. The trabecular portion of the bone provides strength and integrity. When we think about osteoporosis, there are many different risk factors that can predispose patients to get osteoporosis. The first category that we think of are lifestyle. Lifestyle factors that would promote osteoporosis are low calcium or vitamin D intake, high caffeine intake, alcohol consumption with the equivalent of 3 or more drinks a day, smoking, and just being thin. There are certain medical conditions that we would also think of that could predispose patients to osteoporosis. These are Cushing's syndrome, hyperparathyroidism, thyrotoxicosis, rheumatoid arthritis, multiple sclerosis, early menopause, and age. Medications can also cause osteoporosis. Medications that we would associate with this would be anticoagulants such as heparins, anticonvulsants, specifically phenytoin, primidone, carbamazepine, phenobarbital, and valproate, aromatase inhibitors, barbiturates, chemotherapy, the depot shots, glucocorticoids, PPIs, and SSRIs. When it comes to diagnosing osteoporosis, there are two main tools that are used. The first is a quantitative ultrasound. This measures bone mineral density, or BMD, of the heel. This can also estimate hip and non-vertebral fracture risk. The second diagnostic tool is a dual energy X-ray absorptionometry, or the DEXA scan. This is the gold standard in diagnosis. It evaluates the BMD and fracture risk by scanning the majority of the body. You can see here on the image to the right, the heel test is being used as more of a screening tool for osteoporosis, whereas the DEXA scan on the left is used for more diagnostic purposes. When discussing osteoporosis, we have to know the difference between a T-score and a Z-score. These essentially will go into the diagnosis of osteoporosis, and T-scores are used more commonly. A T-score measures the number of standard deviations your bone mineral density is from a young, normal, healthy population average. A Z-score, on the other hand, compares your bone mineral density to people in the same age, sex, and ethnicity groups. If you see the example in the chart of the patient in the red dot, the red dot depicts a bone mineral density of a patient who is 60 years old. Her Z-score is only negative 0.5 or 0.5 standard deviations below the average patient population for her age, ethnicity, and sex. You can see that it's not very far away from the white line that we would normally, which depicts the normal bone mineral density for someone of her matched score. On the other hand, her T-score is negative 2, and this is because compared to a normal, healthy population, she is 2 standard deviations lower than this population when it comes to bone mineral density. So, as I stated before, the diagnosis of osteoporosis is largely based on the T-score, not the Z-score. So, normal bone mineral density is when you are within 1 standard deviation of mean level for young adult reference range population. And so, this would be a T score of -1 or greater. Low bone mass, or osteopenia, is when your bone mineral density is between 1 and 2.5 standard deviations below that same young adult reference population range. So a T-score of -1 to -2.5. Osteoporosis is when you are 2.5 or more standard deviations below that average young adult reference population bone mineral density. So this would be a T-score of 2.5 or lower. Additionally, you can have severe or established osteoporosis, and this is essentially osteoporosis plus the fact that you've had at least 1 fracture. Now that we've talked about how to test for osteoporosis, we need to know what types of patients should be tested. All women 65 years and older and men 7 years over age 70 should be tested for osteoporosis. Younger postmenopausal women or men with clinical risk factors for fracture should be tested. Adults who have had a fracture at or after age 50. Patients with a condition or taking a medication associated with low bone mass. A common example would be a patient who has rheumatoid arthritis who's taking a prednisone dose of at least 5 milligrams a day for at least 3 months. Lastly, all patients receiving treatment or considering treatment should be tested for osteoporosis. Once we test patients, which of those patients need to be treated for osteoporosis? Any patient who is a postmenopausal female or a man over age 50 years old who present with any of the following should be treated. If they present with a hip or vertebral fracture, if they have a T-score of less than 2.5 at the femoral neck, total hip, or lumbar spine, or if they have low bone density or osteopenia at femoral neck or lumbar spine, and any of the following: a 10-year probability of hip fracture of 3% or greater, a 10-year probability of a major osteoporosis fracture of 20% or greater. These two probability calculations are calculated using the Fracture Risk Assessment, or FRAX tool. The FRAX tool takes into account age, gender, low BMI, prior osteoporotic fractures, femoral neck, BMD, whether or not they have rheumatoid arthritis or use prednisone, secondary causes of osteoporosis such as type 1 diabetes or chronic malnutrition, parental history of hip fractures, smoking status, and alcohol intake. All patients who have an indication for prevention or treatment of osteoporosis should be educated on the non-pharmacological interventions that will help them in the future. They should all be doing light weight-bearing exercises, decreasing the intake of caffeine, smoking cessation, and they should limit their alcohol consumption. Pharmacologic interventions include calcium and vitamin D supplements, bisophosphonates, selective estrogen receptor modulators or SERMs, calcitonin, teriparatide, or denosumab. Calcium and vitamin D intake are very important to address in all patients in order to prevent and treat osteoporosis. All patients should get at least 1,200 milligrams per day of dietary calcium. Women over the age of 50 should receive 1,200 to 1,500 milligrams of elemental calcium daily. Adults over 50 years old should have vitamin D intake of 800 to 1,000 units daily in order to maintain bone health. The majority of calcium intake for patients should ideally be from dietary sources. Some evidence suggests that calcium supplementation may be potentially harmful with regard to cardiovascular events and could increase calcium deposits on the heart. For this reason, we want to promote dietary intake of calcium. If you look below, this is a good tool that you can use to calculate the amount of calcium that patients are getting from different types of dietary sources. You'll see that milk and yogurt have 300 milligrams per serving of calcium. Cheese has 200 milligrams per serving, and fortified um, foods or juices can really range anywhere from 80 to 1,000 milligrams of calcium per serving. What you then do is add up all of the patient's dietary intake throughout the day in order to get the total dietary intake per day, and then you can subtract that from their total daily needs in order to figure out how much supplementation that they will need. There are many different calcium formulations that patients can take in order to supplement their calcium levels. Each of the different calcium formulations has a different percentage of elemental calcium per milligram strength. You'll see that calcium carbonate, the brand names are Oscal or Caltrate, has the highest amount of elemental calcium per milligram basis. The lowest calcium amount per milligram, elemental calcium amount per milligram basis, is the calcium gluconate. You'll see that with calcium carbonate and calcium phosphate that these need an acidic atmosphere in order to be best absorbed. You may consider counseling your patients on taking this with an acidic beverage like an orange juice. We also want to keep in mind that these may not be the best formulations to give to a patient who's on a PPI or H2RA therapy for acid suppression. Another important note to keep in mind is that calcium absorption is saturable. For this reason, you need to divide doses for a maximum dose at one time of 600 milligrams. Most patients will be requiring 600 milligrams twice daily. Possible side effects of calcium supplementations include constipation and flatulence. There are some drug interactions as well with bisphosphonates and antibiotics such as fluoroquinolones and tetracyclines and levothyroxine. With these drug interactions, we essentially just need to make sure that patients are separating the dosing because calcium can bind these agents and inhibit absorption. The second therapy that we'll talk about for osteoporosis are bisphosphonates. These work by inhibiting osteoclast activity. They can come with many different side effects, including GI effects such as constipation, flatulence, and abdominal pain. There is a risk for esophagitis and esophageal ulcers and erosions. They can cause myalgias. There can be an acute phase reaction with reclass, which is the IV formulation that includes muscle aches, headaches, fever, and we can avoid this by pre-treating with acetaminophen. There's a rare but serious side effects of osteonecrosis of the jaw, so all patients should be sure to have regular dental visits while on these agents. And lastly, there is a risk for atypical bone fractures. These are rare but usually occurs after over 5 years of use and are usually preceded by pain in the thigh or groin area. Most of the time, the length of therapy for bisphosphonates is anywhere from 3 to 5 years. Directions for the oral medications include taking it with 8 ounces of water at least 30 minutes before breakfast, beverages, or other medications. You have to wait 60 minutes for abandronate specifically. Another important counseling point for patients is not to lie down for 30 minutes after taking the medication. This will help prevent the esophagitis or esophageal ulcers that can be a side effect of the medication if patients lay down too quickly. Below are listed the different choices of bisphosphonates for either the prevention or the treatment of osteoporosis. You can see that the doses may vary depending on whether the indication is prevention or treatment. For alendronate, this is a weekly formulation for both prevention and treatment, and this has been shown to reduce hip and spine fractures by 50% over 3 years of treatment. Abandronate is a monthly treatment and can be given orally, monthly, or IV every 3 months. Abandronate reduces the incidence of spine fractures by 50% over 3 years, but non-vertebral fracture risk reduction has not been documented. This would be something to keep in mind for patients who have low bone mineral density in areas other than the spine. Risendronate is also indicated for prevention and treatment, and this can be a daily, weekly, or monthly or 2 days out of a month in terms of dosing. Risendronate reduces spine fractures by anywhere from 41 to 49% and non-vertebral fractures by 36% over 3 years. Lastly, zoledronic acid is an IV infusion that can be given every 2 years for prevention or yearly for treatment. Zoledronic acid reduces spine fractures by 70%, hip fractures by 41%, and non-vertebral fractures by 25% over 3 years. Another medication that can be used in the treatment of postmenopausal osteoporosis only when other alternative treatments are not suitable is calcitonin. The mechanism of action of calcitonin is that it inhibits osteoclast activity. It reduces vertebral fractures by about 30%, but there's no evidence in use in non-vertebral fractures. The dose of calcitonin is either 200 units as a nasal spray daily, alternating nostrils, or you can do 100 units intramuscularly or subcutaneously daily. These need to be stored in the refrigerator until opened, and then up to 30 days at room temperature thereafter. Side effects of the calcitonin depend on the route of administration. With the nasal spray, you can get rhinitis, epistaxis, and with the intramuscular or subcutaneous injection, you can get injection site reactions. Other side effects that are possible include flushing and there is a possible association with malignancy. Patients with calcitonin also need to be ensured that they're taking adequate amounts of calcium and vitamin D so that their calcium levels don't drop too low. Raloxifene is another medication that can be used in the prevention or treatment of osteoporosis in postmenopausal women. This is a medication that's also used in order to reduce the risk of invasive breast cancer. This medication is in the SERM class um, of medications, and it's been shown to reduce the risk of vertebral fractures from anywhere from 30 to 55% over 3 years. The dose is 60 milligrams daily. Possible side effects with raloxifene include hot flushes, deep vein thrombosis, peripheral edema, and vaginal bleeding. Contraindications include pregnancy and history of thromboembolic disorders. Teriparatide or Forteo is another option for patients with osteoporosis. It's used specifically in the treatment of postmenopausal women and men with osteoporosis at high risk of fractures. It can also be used in patients in the same population if their osteoporosis or fracture risk is due to systemic glucocorticoid therapy. The way that this medication works is that it's a recombinant form of the parathyroid hormone, and it's a daily treatment that stimulates osteoblasts. It's been shown to reduce the risk of vertebral fractures by 65% and non-vertebral fragility fractures by 53% over 18 months of therapy. It's a 20 microgram subcutaneous daily injection. Possible side effects of teriparatide include transient hypercalcemia, chest pain, dizziness, rash, nausea, vomiting, and injection site reaction. There is a black box warning for this medication because it can increase the risk of osteosarcoma, which where the risk increases the longer the medication is used. For this reason, the length of therapy for teriparatide is no more than 2 years. Denosumab or Prolia is the last medication we'll discuss in terms of osteoporosis treatment. This medication is indicated in osteoporosis in men or postmenopausal women at high risk of fracture. This medication works by preventing osteoclast formation. It has been shown to reduce the incidence of vertebral fracture by 68%, hip fractures by 40%, and non-vertebral fractures by 20%. The dose is a 60 milligram subcutaneous injection once every 6 months. Contraindications to Prolia include hypocalcemia. Adverse effects can include fatigue, hypocalcemia, eczema or rash, arthralgias or limb pain, cough, and injection site reactions. Whenever patients are on any sort of therapy for osteoporosis, it's important to maintain ongoing monitoring of these patients. They'll need a bone mineral density test every 1 to 2 years after treatment is initiated, then every 2 years thereafter. You can do it more frequently if clinically indicated, and you could potentially do it less frequently if they don't have any major risk factors and their initial T score was within normal or upper low mass range. No therapy should be considered indefinite. Throughout a patient's therapy, we should always be weighing the risk and benefits of continuing therapy, as well as paying attention to the length of therapy. The length of therapy depends highly on the agent that you're using.